Oh, okay, open.
And bariatric surgery. Open.
Okay, okay.
And
open.
bariatric surgery.
In this turn area, strain age, we wouldn't really do open for appendix. But even otherwise, I'll address your question. Yes, suppose a patient comes with a DU perforation, this group. Yes, the management would be along the same lines. And yes, we would put in invasive lines. We can see that pulse pressure variation very much better, so you'll be guided by that for fluid management. And also, they will need to be most likely slow emergence would be better. So you send them intubated if you feel that patient cannot be extubated on table, because a large incision, and I don't think epidural is really that easy. And also, if it is an emergency, we wouldn't really, if the patient is septic, we wouldn't do an epidural. But if you can get in an epidural, yes, you may consider extubating on table. But low threshold for keeping the patient intubated and sent to ICU where he can be extubated and managed appropriately.
Third category of patient, emergency surgery. For example, perforation, where we cannot get enough time for pre-operative assessment and preparation. So what to do in that case?
I think, in fact, in many of what I mentioned earlier is we consider all our patients to have real bad obstructive sleep apnea. So that is how we plan our anesthetic and our post-op care. So I think if you have the same approach or similar approach, but also plan to have these patients ventilated post-operatively, make sure there's an ICU bed. That would be a best approach.
Post-operative care is more important for emergency patients.
Yes.
Okay.
Yeah,
Thank you very much.
Yeah. And also the emergency fluid management, as I said, pulse pressure variation, all those things are important. Invasive lines.
Thank you.
Sir. No, I was just going to add to the same comment to give a short answer. In an emergency, you have no choice. So you've got to do what you have to do. If you treat all your patients as bariatric patients, or think all your patients as obese patients and you take all the precautions, and that is the answer. But I think, as he said, and in this day and age, open procedure for a very obese patient, you should advise them that they should go to a laparoscopic surgeon if they can, because laparoscopic surgery will have a better result than opening them, and therefore, that's the answer. But if it's an emergency, you can't help it.
Excuse me.
Thank you.
I would like to thank our chairpersons, Professor Radhakrishna Rao and Professor Dayal Singh, as well as our speakers, Professor Dr. Pankaj Kundra and Dr. Murali Pandurangan. Thank you very much, sirs.
For the kind attention of Dr. Suresh Kannan, sir, you are wanted by Professor Kundra, who's waiting outside near the registration counter. Another announcement, tea and snacks are being served throughout the day. There will not be separate tea break. Next up, we have a video session on the topic, Crisis Management, How to Get It Right. For this, I'd like to invite Dr. Ashoka Balakrishnan. Sir is a simulation faculty member of National University Hospital, Singapore. He also holds the distinction of being a faculty member at Anesthesia Simulators, Malaysia. Sir has certified in Comprehensive Trauma Life Support, Australia. He also received the Best Paper Award in Annual Intensive Care Society Conference, Malaysia. A warm welcome to you, dear sir.
Good morning, everyone. I'm Ashoka, and thanks for the introduction. My esteemed teachers, faculty, and anesthesia colleagues here, this is a 15 minutes race against time. So I would try to make as interesting as it can go.